Second white coat. Subscribe and like. Let's learn medicine together.
Today we're going to jump into a real medical detective story. It all starts with something super common, something you've probably dealt with a million times, a simple childhood earache. But then it escalates into a full-blown, life-threatening brain emergency. So the big question is, how on earth does that happen?
Yeah, that's really the heart of it, isn't it? It just sounds like a crazy leap. You've got a fussy toddler, they're pulling at their ear, and then suddenly it's a major crisis in the ER. But believe it or not, there is a direct, and pretty scary, path that connects those 2 points. And today, we're going to follow that trail. All right, let's set the scene. Imagine you're in the emergency department. Our patient is a 2-year-old girl, and she is not doing well. Her symptoms have been getting worse, and as you can imagine, her parents are just beside themselves with worry. So what's her story? Well, she's had a bunch of respiratory infections lately, and then you see that classic telltale sign of an ear infection, what we call otitis media. She's super irritable, and she's constantly pulling at her ears. But here's where things take a really scary turn. Her fever is getting worse, she's vomiting, she's incredibly tired and lethargic. And then, the thing that sends up all the red flags, a sudden, generalized seizure, right there in the ED. At that point, the whole medical team knows this is not just a simple ear infection anymore.
Okay, so when a sick kid has a seizure, your first thought is, we need to see what's going on in the brain, right now. So they rush her for a CT scan. And what comes back? It's the first huge clue, the first big break in the case. It's something so visually striking, I like to call it the ring of fire.
And here it is. This is the image that changes the entire game. The scan shows a solitary, that just means a single one, a 2-centimeter ring-enhancing lesion. And look where it is, in the left lateral temporal lobe. You know, for the doctors, this is the smoking gun. It's screaming brain abscess.
Okay, ring-enhancing lesion. That's a mouthful of medical jargon, right? So let's break it down. Think of it like the body's attempt to quarantine a really bad infection inside the brain. In the very middle, you have a core of pus. Around that, the body builds a little wall, a capsule that's full of blood vessels. When they inject the CT contrast dye, that wall just lights up. That's the ring. And then all around that ring, you get a ton of swelling, what we call edema. So we've got the scan, we've got the symptoms. Now we have to put the puzzle pieces together. How did this one single spot in the brain cause such an absolute catastrophe for this little girl?
It actually lines up perfectly. The fever and exhaustion, that's her body's immune system going into overdrive fighting the infection. The vomiting and that really deep lethargy, that's because all that swelling, that edema, is literally squeezing her brain and jacking up the pressure inside her skull. And the seizure, well, you've got this angry, inflamed abscess sitting right on the surface of the brain, irritating it. That irritation is what sets off that chaotic electrical storm we call a seizure.
Okay, so we know what it is, a brain abscess, and we know why it made her so sick. But the next big question for our detective work is, how did it get there? How in the world did bacteria get past all the brain's defenses to set up shop? And this is where you have to put on your detective hat. The biggest clue we have, by far, is its address. It's all about location, location, location. This abscess didn't just pop up in a random spot. The fact that it's in the temporal lobe is like a giant flashing neon sign pointing us right to where it came from. So think about it. What is right next door to the temporal lobe? And here's the journey that bacteria took. It all starts with that middle ear infection. From there, the infection creeps into the bone right behind the ear, the mastoid bone, which is kind of like a honeycomb of little air cells. When that gets infected, we call it mastoiditis. And from there, well, the temporal lobe is literally right on the other side of that thin bone. The infection just eats its way straight through and forms the abscess. It's a direct invasion, what doctors call contiguous spread. Now, like any good detective, you can't just fixate on your number one suspect. You got to rule out the other possibilities to make sure your case is rock solid. So let's quickly consider the other ways bugs can get into the brain, just to be sure we're on the right track. This is a really important rule of thumb. If you find just a single abscess, like in our patient, it almost always means the infection came from somewhere right next door. But if you find multiple abscesses scattered around, that tells you the bacteria probably hitched a ride in the bloodstream from somewhere far away, like an infection on a heart valve or in the lungs. So the fact our patient has just one abscess, it's a massive piece of evidence pointing right back to that ear. So what about another next-door neighbor, like the sinuses?
Could the infection have come from there? Well, no. It's all about anatomy. Infections from the sinuses up front, the frontal or ethmoid sinuses, they spread to the frontal lobe. It's just simple geography. Our abscess is in the temporal lobe. Wrong neighborhood, so we can cross that one off the list.
We can also rule out the danger triangle of the face, that area around your nose and upper lip. An infection there can be bad news for sure, but it causes a totally different problem. The veins there can drain backwards and cause a massive clot in the brain. The symptoms are completely different. We're talking major headaches, problems moving your eyes. It just doesn't fit our patient's picture at all.
And there you have it. We followed the clues, we connected the dots between her symptoms and that CT scan, and we traced the path of the infection all the way back to its source. The case is pretty much solved. So let's just boil this all down to the one big, high-yield lesson you need to walk away with.
This is the pattern I really want you to remember. It's a classic triad. First, you've got the story, a history of otitis media symptoms. Second, you have a dramatic turn, a brand new fever and a seizure. And third, you have the picture, that solitary ring-enhancing lesion, specifically in the temporal lobe. You put those three things together, and boom, you can be incredibly confident you're looking at a temporal lobe abscess that came from an ear infection. It's just such clean, powerful logic, right? You've got a single abscess, you've got a clear story of an ear infection, the simplest explanation, contiguous spread, is almost certainly the right one. It's a beautiful example of how the patient's history and the imaging have to fit together like a lock and key. And that really is the big takeaway here. This whole case is a powerful reminder that sometimes the most common, everyday illnesses can be hiding something truly dangerous. It really makes you think, doesn't it? What other subtle clues might we be missing in common sicknesses that could be signaling a much, much deeper problem lurking just out of sight?